I will carry on. Okay, so I'm going to discuss epidemiology and mechanisms of COVID coagulopathy in hospitalized patients with this disease. Just an important disclosure is that I'm a co-principal investigator of the RAPID trial. So we're going to go through thromboinflammation that we now know is a characteristic of COVID-19 and discuss epidemiology and some mechanisms or our understanding of it as it currently stands. So here I'm going to present some observational data describing an increased risk of venous thrombosis in patients with COVID-19. This was published in 2020 in RPTH, and at the time there was already enough data to develop a systematic review and meta-analysis of the literature. And as you can see here by this forest plot, you're going to see a ton of research activity really quickly throughout the pandemic. And really variable estimates of the risk of thrombosis in this patient population. So there were these repeated reports of thrombosis that really a lot of indicators of this began when the pandemic started to move west, especially in Italy. When patients were admitted to hospital. And this led to our understanding in those who did not have routine screening for deep venous thrombosis, that those who were admitted to hospital had event rates of about 9.5%. And of course, it would be higher if you were screening asymptomatic patients. Also, it became clear that ward patients were less affected by venous thrombosis than those in the ICU, with estimates approaching 8% in the ward and 22% in the ICU. And here I'm showing the pooled VTE prevalence in non-ICU to the left versus the ICU patients in the right. So it seems to be much higher risk amongst those in the ICU. And so why is it that we're seeing such large differences in these estimates, right? So some of it has to do with the study design, and most importantly, whether or not screening for deep venous thrombosis was part of the study protocol or not, but also taking into consideration the clinical setting, in particular the standard of care, which varied wildly throughout different geographical regions. And also because there are different baseline biological differences with regards to the baseline risk of venous thrombosis in different patient populations. So for example, the reason why we have that early data from Wuhan, China, indicating that patients who were treated with heparin thrombotic prophylaxis had a lower 28-day mortality if they had a high D-dimer compared to those who did not, is because it was not considered standard of care at the time to provide venous thrombosis prophylaxis to patients in China, because their baseline risk of venous thrombosis is much lower than what we see in the Western world. Now, what we are seeing in patients with COVID-19 ARDS versus those with other viral types of ARDS. So is there a difference in these two patient populations? And so this study looked at 150 patients with COVID versus approximately 150, a historical control group with non-COVID ARDS. And again, it seemed as if there was a much higher risk of thrombosis in those with COVID versus those who do not. Granted, our ability to make observations right now in COVID is truly unprecedented. And, we've never had the opportunity to evaluate in depth another type of virus in the same way as we have had the opportunity with COVID, fortunately / unfortunately. And so we just have to take these estimates with a grain of salt. And then also looking at COVID ICU patients versus non-COVID ICU patients with ARDS. Again, we are seeing more cases of pulmonary emboli or in situ pulmonary thrombosis in those with COVID versus non-COVID ARDS. So why is there this increased risk of thrombosis in COVID-19? Well, a lot of this relates to the tremendous crosstalk between our hemostatic systems and our inflammatory systems. And so in the presence of endothelial damage, there is resultant inflammation that leads to platelet activation, expression of a bunch of prothrombotic proteins, loss of normal anticoagulant effect that occurs physiologically, and inhibition of fibrinolysis. And this is because we are rigged evolutionarily in the face of stress and inflammation and release of various cytokines and chemokines and hormones such as epinephrine and norepinephrine, that in the face of physiological stress that we ramp up our coagulation system to prevent us from potentially bleeding to death. Because if you consider us as hunters and gatherers, one of the biggest risks to our lives was injury, either because something was hunting us or we were hunting something else, and we could fall, injure ourselves, or get attacked. And so we are still rigged in one such way to amp up our coagulation system in the face of stress. Now, all of this leads to additional downstream effects, including the development of a lot of key mediators of the immune system, including complement. But a lot of this leads to additional crosstalk between our coagulation system and leads to thrombin generation. And very importantly, the development of neutrophil extracellular traps known as NETs. And NETosis is very well known now to be a strong promoter of platelet aggregation and thrombin generation. And so all of this very delicate, coordinated crosstalk leads to an increased risk both of micro and macro thrombosis. And so what is most important, however, in patients with COVID-19 is this concept of in situ pulmonary thromboinflammation. And so this local inflammation and hypoxia leads to endothelial cell activation and injury and extensive tissue factor expression. This ultimately leads to a loss of natural anticoagulants, the natural heparins that exist within our body, and local thrombosis. And so while we call, thrombotic events that occur in the pulmonary vasculature, pulmonary emboli, it's more likely that these are in situ pulmonary thromboses that are occurring. And it was shown very early on in the pandemic that there were postmortem findings in patients with COVID-19 indicative of microvascular thrombosis and secondary hemorrhage in the lungs. And so is there any laboratory evidence of these hemostatic derangements in patients with COVID-19? And yes, there is. And so here I'm presenting the typical laboratory parameters in patients who've survived versus those who have not survived with COVID-19. Now, really interestingly, you will see that thrombocytopenia is not a typical feature of COVID-19. As a hematologist, this was really surprising for myself, and I think the community of hematologists worldwide, in that we are so accustomed to seeing thrombocytopenia in association with viral illness. But there's something very different about COVID-19, and we were not seeing this. So thrombocytopenia is typically not a feature. As well, prolongation of clotting times, in particular the prothrombin time, is also really not typically a feature unless patients progress to more systemic evidence of coagulation activation, i.e. DIC. Similarly, hypofibrinogenemia is not a feature except in those who are severely ill and subsequently die. And in fact, hyperfibrinogenemia, indicative of very active coagulation, is much more so a feature. Now, finally, I'd like to just talk about D-dimer. So D-dimer is an assay that is very, very well known, and I'm going to speak about it a little bit more in a few future slides. But it became clear that the D-dimer was the best summative biomarker of coagulation in patients with COVID-19 thromboinflammation. And an elevation in D-dimer really seems to be marked in patients with COVID-19, and the higher the D-dimer, the higher the risk of death. And so in summary, the laboratory characteristics of COVID-19 are a mild or moderate, if any, degree of thrombocytopenia, very slight prolongation of the prothrombin time or increase in the INR in very few patients, typically occurs only when they're really sick. A very high fibrinogen is classic in these patients, but low levels can occur, but typically in patients, again, who are very, very sick. And a very elevated D-dimer is something that is very commonly seen, and extreme elevation in D-dimer is seen in those who do not survive. So I just also want to give a bit of a plug here. So this image here comes from an illustrated review that was put together by Drs. Levy and Hunt And this is an illustrated review that was published in RPTH, which is a subsidiary journal of JTH. And I now have the pleasure of being their new associate editor for illustrated materials. So I'm going to put this out as a plug. If anyone has any interest in developing illustrated materials for our journal, please do reach out to me. I am on Twitter and would be happy to hear if anybody has some interesting information that they would like to knowledge translate visually. And so let's sort of zoom in on the D-dimers a little bit more. Why is the D-dimer so helpful in this disease? What is it telling us about this disease? And so it's telling us a few things. So it's telling us that there's likely systemic thromboinflammation and thrombin generation with subsequent fibrin breakdown. So D-dimer is the breakdown product of fibrin linked to factor 13. So it tells us that not only has a blood clot formed, but a stable one has formed. And in addition, there's tremendous fibrin turnover in the lung due to severe pulmonary inflammation. So as I said earlier, I was going to talk a little bit about what D-dimers tell us in hospitalized patients. So D-dimer, as I said, is a marker of coagulation and fibrinolysis. And historically, it was really particularly helpful to rule out a venous thromboembolic event if it was negative in a patient with a low pretest probability. It also could help us evaluate for disseminated intravascular coagulation and also to consider extended VTE prophylaxis in medical patients. Importantly, there are many, many different D-dimer assays, which is why it is very difficult to standardize this assay and to describe the findings of these assays in clinical trials, for example, which is why in all the clinical trials of COVID-19, you're seeing them report D-dimer values as a fold increase above normal, not giving you the actual value because different labs use different assays on different instruments. And all of this leads to very disparate results. Now, there are many, many conditions that have an elevated D-dimer, including physiologic conditions such as pregnancy, also cancer, advanced age, liver, and renal failure. So as I said, D-dimer is the best biomarker predictor of a few things in COVID-19, but very much so a predictor of thrombosis. In fact, in patients who had a D-dimer that is above 2 times the upper limit of normal, which is above 1,000 in this particular assay, that the relative risk was above 3 for an underlying venous thromboembolic event. Now, does the presence of thromboinflammation correlate with the risk of poor outcomes other than large vessel thrombosis? So I've just told you that it increases the risk, or it can be predictive of underlying thrombosis, but what about other important outcomes? Well, turns out that coronaviruses as a family in general seem to have a very specific effect on fibrinolysis that correlates with lung injury. And so we think that this impact that these viruses have specifically on enhancing plasminogen activator activity and increasing fibrinolysis is a particular feature of coronaviruses, especially the SARS-CoV virus itself. And this leads to fibrinolytic activation, which may be correlated with an increased risk of capillary leak. And so this means that D-dimer in itself is an indicator of severity of lung disease and ARDS potentially in these patients. Also importantly, in that similar study that I presented before, not only was D-dimer a best predictor of thrombotic complications, but also of bleeding complications. And so this is something that we need to be very mindful of in patients who have a markedly elevated D-dimer. Now, most importantly, those with extremely high D-dimer values are also at increased risk of death. And so these COVID-19 deaths relate, therefore, to its underlying thromboinflammatory nature. And so when you have the infection with a bunch of particular susceptible variables, such as advanced age, underlying comorbid illness, etc., that this leads to progressive endothelial damage and thrombotic events, whether on the micro or macro level, that contributes to multi-organ failure. And so what's really important about thromboinflammation is to consider it as one of two different types of aspects that are going on at the same time, meaning that thromboinflammation puts these patients at increased risk for large vessel thrombosis, but it's the direct endothelial injury that also puts these patients at increased risk for lung injury and microthrombi. So this is pretty exciting for us to become aware of early on in the pandemic, because this suggests that the hemostatic system itself might be a therapeutic target, and that anticoagulation might affect this disease severity by addressing hemostatic signaling, risk of thrombosis, risk of lung injury, and subsequently risk of death. And also that different types and doses of anticoagulants might have different effects, and so we cannot pool them all in the same group. Also, this idea that thromboinflammation might be a mechanism of COVID-19 severity and leads to a progression of various different stages of COVID-19. And this might be very tightly linked to it, which is why clinical trials are needed to guide care, and that we need to view these different patient populations as differently. And also, what's really important is to ensure that we are evaluating key outcomes. In this patient population, of course, we're interested in the risk of death, but we're also interested in indicators of organ support, such as mechanical ventilation, as well as other important outcomes, including bleeding and thrombotic events. So in the clinical trial that I was involved in, we were interested in heparin, and there are many trials that have been interested in heparin. And this is because there's a value to heparin beyond its anticoagulant effect, in that it has been shown in numerous animal models that heparin has a beneficial effect on endothelial function and capillary leak, and improves acute lung injury in animals. And also because heparin itself might interfere with viral attachment entry in this specific virus, and also because heparins have anti-inflammatory effects in acutely ill medical patients, including those with COVID-19. In fact, low molecular weight heparin has been shown to decrease IL-6 levels in these patients. And also, most importantly, is it's a really effective anticoagulant. So we know that it is effective at large vessel thrombosis and its prophylaxis and also in its treatment, but also has a really well-known safety profile. It has been available for care for 70+ years. And we know that if we're able to lower the risk of thrombotic events, which is very high in patients with COVID, that independently of the separate processes of thromboinflammation increases the risk of death. Obviously, we're interested in affecting thromboinflammation and reducing small vessel thrombosis. As I said, that we think that this is correlating with the need for increasing organ support and death. And also, finally, because heparin is so well known that when bleeding does occur, we know what to do. And so the takeaway messages here is that COVID-19 is thromboinflammatory in nature. It has multiple hemostatic effects. That thromboinflammation appears to correlate with disease severity and risk of death. And it's the D dimer that's truly the hallmark of this COVID-19 coagulopathy. That heparin anticoagulation is truly an important therapeutic modality to consider, particularly in those who are moderately ill with COVID-19. And that the value of heparin extends beyond its anticoagulant effects. Thank you very much, and I'm happy to take any questions.